good morning to everyone in the room and hello from Germany. My name is Cordula Fassbender, Apheresis Research Institute, Cologne. I'm speaking today on behalf of Professor Reinhard Klingel, the head of our institute and a member of Global DARE's Scientific Advisory Board. My academic background is in biochemistry, immunology, and biology. And at the Institute, we have specialized in clinical research, development, and quality assurance of extracorporeal blood purification procedures, but we do not treat patients ourselves. I'm very pleased to present the conclusions of the Apheresis Workgroup. The purpose was not to make treatment recommendations today. It was to identify what we know, what remains uncertain, and what data we need in order to make better decisions in the future. Okay. Therapeutic apheresis is not one single treatment. It is an umbrella term for a broad range of extracorporeal blood purification procedures. On the one hand, there are different technical approaches. These include plasma-based procedures, such as plasma exchange or selective plasma filtration, and whole blood procedures, such as adsorption techniques. On the other hand, therapeutic apheresis is used across a wide range of diseases. Its role depends on the underlying condition, the pathogenic factor to be removed, and the clinical situation. In many indications, apheresis is used in acute, severe, or treatment refractory situations, sometimes as a rescue treatment or last therapeutic option. In other conditions, it may be used repeatedly as part of long-term disease management. For adult refsum, the question is where apheresis fits within this spectrum, as an acute intervention, as chronic maintenance therapy, or potentially both. Therapeutic apheresis is a procedure for blood purification. In adult refsum, the goal of therapeutic apheresis is to lower dangerously high concentrations of circulating phytanic acid and support clinical stabilization during severe deterioration. However, it is important to be precise. Apheresis does not correct the genetic or metabolic cause of the disease. It's a supportive treatment intended to reduce the phytanic acid burden in the circulation. The starting point is clear. Dietary management remains the cornerstone of the treatment. Reducing phytanic acid intake, maintaining adequate calories and carbohydrates, and avoiding fasting or catabolism are essential. However, in some patients, particularly during acute metabolic or neurological deterioration, phytanic acid levels may rise rapidly, and clinical deterioration can be severe. In this situation, apheresis may provide a way to reduce circulating phytanic acid quickly. Apheresis is already used internationally for adult refsum, however, in highly variable ways. The key question is whether this acute biochemical effect also translates into meaningful long-term clinical benefit. There are two different approaches. One is plasma exchange. Plasma exchange is a traditional, unselective method of extracorporeal blood purification treatment. Blood is taken from the patient through a vascular access and passed through a separator or a centrifuge. In the separator, the plasma liquid component of the blood is separated from the blood cells. The plasma is then discarded. Because plasma is removed, it has to be replaced with a substitution fluid, usually albumin solution and, in some situations, fresh frozen plasma. So, in simple terms, we remove the patient's plasma, replace it with a suitable fluid, and return the blood back to the circulation. This can be effective in lowering phytanic acid plasma concentrations, but it also removes useful plasma proteins. Replacement with donor-derived proteins carries a risk of allergic reaction and, in very rare cases, a risk of virus transmission. Plasma exchange is widely used internationally. In clinical practice, the terms plasma exchange and plasmapheresis are often used interchangeably. The other method is lipoprotein apheresis, which is a more selective procedure. During lipoprotein apheresis, the separated plasma is not discarded. It is passed through a special filter. The filter removes lipoprotein fraction carrying phytanic acid while preserving most plasma proteins. No replacement with donor-derived proteins is needed. The patient receives their own cleaned plasma back. This is particularly important in long-term treatment because it helps avoid depleting the patient of essential plasma components. Availability of lipoprotein apheresis varies between countries and healthcare systems. Both procedures can lower circulating phytanic acid, but they differ substantially in selectivity, treatment burden, access, and suitability for repeated long-term treatment. The rationale for lipoprotein apheresis is based on phytanic acid transport in plasma. Phytanic acid is not freely dissolved in blood. It is transported on lipoprotein particles, including LDL and VLDL. Therefore, selective removal of these particles can substantially reduce plasma phytanic acid. This is a strong biological rationale. However, it is important to distinguish between a plausible mechanism and proof of long-term clinical benefit. In Germany, lipoprotein apheresis is already an established outpatient treatment for selected patients with severe familial hypercholesterolemia and elevated lipoprotein (a), usually on a weekly or bi-weekly basis. This creates a specific infrastructure and clinical experience that is not directly comparable with many other countries. Within this system, a small number of patients with adult refsum are also treated regularly with lipoprotein apheresis. However, reimbursement is not automatic. It is generally considered only in severe individual cases, particularly when phytanic acid levels are very high and there is a significant clinical deterioration or high risk of further damage. Even for severely affected patients, approval can be difficult. Reimbursement always requires an individual application, detailed clinical justification, and may still be denied by the health insurance provider. So access to chronic treatment is not only a medical question, but also an important issue of healthcare system structure and reimbursement. What we observe in clinical practice. The treatment data were kindly provided by the patient and are presented with the patient's permission. Like many people with adult refsum, this patient experienced a long diagnostic delay of approximately 27 years. At diagnosis, retinitis pigmentosa and hearing impairment were already advanced, and they had developed polyneuropathy. Under regular lipoprotein apheresis, they had remained clinically stable. This is particularly relevant because at this stage, the goal may not be to reverse damage that is already irreversible, but rather to prevent further deterioration and preserve function. The graph shows the phytanic acid values over 26 months of weekly lipoprotein apheresis. The sawtooth-like pattern is very typical. The upper points are the values before treatment and the lower points are the values immediately after treatment. Each treatment procedure produces a marked drop in circulating phytanic acid. But the level rises again between sessions, sometimes quite rapidly, even though the patient follows a strict low phytanic acid diet. This supports the idea that phytanic acid is not only coming from current dietary intake, but is also redistributed from body stores into the plasma. Importantly, in the longer term, the pre-treatment levels appear to become lower in some patients. This may suggest that regular treatment together with diet can gradually reduce the patient's overall phytanic acid burden. One possible explanation is that lipid apheresis treatment creates a steep concentration gradient between the plasma and other body compartments. Phytanic acid is first removed from the intravascular compartment, where it is carried on circulating lipoproteins. This may be followed by a relatively rapid redistribution of phytanic acid from the interstitial space back into the plasma, contributing to the rebound seen within days. Over a longer time scale, phytanic acid may also redistribute from more slowly exchanging tissue stores, including adipose tissue, liver, peripheral nerves, or other organs. Repeated treatment could therefore potentially reduce the total phytanic acid burden over time. However, this remains a working model. We need studies that can test this hypothesis. This slide summarizes the balance between what is already supported by clinical experience and published evidence and what still needs to be clarified. We know that apheresis can rapidly lower circulating phytanic acid. We also know that clinical benefit has been reported in case reports and case series, especially in patients with acute deterioration. Apheresis has been used in adult refsum for decades, and both plasma exchange and, in some countries, lipoprotein apheresis are available in experienced centers. At the same time, several important questions remain open. We do not yet know which patients benefit most, whether chronic apheresis can truly modify long-term disease progression, or when treatment should ideally begin. We also lack a validated biomarker that could reliably reflect disease activity or replace repeated clinical assessment. And finally, there is no evidence-based standard for treatment frequency. Some patients receive a short acute treatment course, while others are treated regularly for months or years. These differences reflect the fact that current decisions are often individualized and based on the severity of the disease, local experience, access, and patient circumstances. So the message is not that we have no evidence. Rather, we have meaningful clinical experience and important observational evidence, but we need more structured longitudinal data to understand how to use apheresis more effectively in adult refsum. There was a strong agreement that the current situation is not ideal. Apheresis is being used internationally, but practice is variable and often based on local experience, local infrastructure access and reimbursement systems. The field lacks of harmonized definitions, standardized treatment data, and meaningful longitudinal outcomes. For this reason, the group saw the natural history study as the most practical and immediate starting point. Our conclusion is that current practice is largely experience-driven. That is not a weakness in itself. In ultra-rare diseases, clinical experience is an important source of evidence, where randomized controlled trials may be unrealistic or impossible. However, we now need to capture this experience systematically so that it can guide future care more reliably. These 4 questions summarize the research agenda. First, when should apheresis be used? Only during acute deterioration or also as chronic maintenance treatment in selected patients? Second, does it improve outcomes that matter to patients, such as mobility, neuropathy, vision, hearing, daily function, and quality of life? Third, how do plasma exchange and lipoprotein apheresis compare in terms of effectiveness, tolerability, access, and burden? And fourth, how should we measure success beyond a single Phytanic acid value? The first priority is not necessarily a randomized trial. It is high-quality, structured data collection. We need to know why apheresis was started, which procedure was used, how often it was performed, and what happened to Phytanic acid levels and clinical outcomes. We also need to record the dietary and metabolic context, because fasting, weight loss, infection, and inadequate carbohydrate intake can profoundly affect Phytanic acid levels. Finally, we need patient-reported outcomes because treatment burden and perceived benefit are highly relevant and in chronic therapy. The barriers are not only scientific, they are also practical. We do not yet have an international cohort that systematically captures who received apheresis, why treatment was started, and what happens over time. Without shared treatment definitions and standardized outcome measures, it is difficult to compare experiences across centers and countries. Limited access to Phytanic acid testing adds another challenge. The result is that valuable clinical experience exists, but it is fragmented. Our next step is to connect and structure these data so that they can generate a clearer understanding. The proposed 5-year roadmap has 3 connected steps. First, we build the evidence base through standardized data collection and an international treatment inventory. Second, we define clinical utility by studying acute and chronic use, procedure selection, and patient-centered outcomes. Third, we create the conditions for future trials by developing validated outcomes, biomarkers, and an international collaborative network. To conclude, apheresis can rapidly lower circulating Phytanic acid, and it has a recognized role in selected acute situations. Chronic treatment is biologically plausible and supported by clinical experience in some centers, but its long-term benefit has not yet been demonstrated with sufficiently robust longitudinal data. Our task is therefore not to overstate what we know. Our task is to build an international patient-centered evidence base that allows future treatment decisions to be more precise, more consistent, and more meaningful for people living with adult refsum.